The doctor is in.
Happy Wellness Wednesday. Happy Woosah Wellness Wednesday. The doctor is in. How you feeling, Ricky?
I am great. I just arrived in the Outer Banks to hang out with my children. They've been here all week. The friends came first, and the mamas and the grandmamas get to come. So I got here about an hour ago, and we'll see what's going to happen. So it's very cool to be with my children. It's like their vacation that they invited us to for a change. What a concept, right?
Love that, and you guys are still in your pod, so your COVID, safety zone.
Right.
Because as much as we like to think that COVID is gone, guess what? It very much is not.
It's
And I think it's important for everybody as we vacation this summer to remember that we still need to protect ourselves. We still need to wash our hands. We still need to do all the things. And we still need to be having these conversations. We started a year ago, over a year ago.
Over a year ago. And
Yeah.
I had a neighbor this morning saying, she's planning a girls trip. She's afraid to go on or do her trip. Like if people are going on planes, and the fear's starting back again, so we just have to be careful. Right.
Yeah, and with that comes, especially as a cancer surgeon, I'm seeing patients who delayed their screening, patients who delayed diagnostic imaging. They felt something and they didn't come in, and for all the different reasons, and it's okay. But we are seeing more advanced disease. We're seeing a lot of breast cancer that is really further along than we'd like, and people need help and they need resources. And today's show is so important so that we can begin to talk about some of these resources like palliative care. I absolutely love talking to patients about this because everybody misunderstands it. And as soon as they say, oh, is that what it is? Then they're very interested in what they can do and how they can utilize those services and how they can just live their best lives. So we should get into it.
Let's get into it. We have some amazing breasties. Well, our Stephanie, my Stephanie breastie friend who I love. And I just met Juliet. So Juliet and I are actually modeling at a fashion show in a couple of weeks for a runway for a cure. And she is like a fierce model. I mean, like really, like when she got up to do her walk, I was like, wow, like she's a real model. It wasn't like the old people like me, but and when I got to know her story, I want to start with her story. We also have Dr. Kim Kersine, who is a palliative doctor that does all this palliative care. So I think we're gonna have a great show. But let's start with Juliet's story because you're going to be blown away by this.
Hi guys, I'm Juliet Copeland, and I am a breast cancer and a couple of cancers survivor, and I'm glad to be on the show, and I thank you for the opportunity to speak publicly about this situation and what we go through. I will say 2018, between the end of 2017 and 2018 was when I kind of got into some medical situations that were uncomfortable. And so it first started out as a blood clot, and we were thinking I was just anemic and getting iron and everything. And then she noticed some things when they did scans over my body. And it came back to be, long story short, 3 different types of blood cancer. I have, what is it called? Oh gosh, lymphoma. I have the non-Hodgkin's lymphoma and the Hodgkin's lymphoma, and which is a weird thing to have at the same time. So, and then also leukemia, and we found out that that was something from a young age that no one ever caught. So, just to be here to this day is an amazing thing. So that's how that started out, and then I kept telling my doctor after the first set of chemo, I was like, I'm back to feeling really bad because I could feel my cancers in me. And so I got to telling them, I'm feeling really bad. I don't know what's happening, but I feel the cancer. I know it's here, so your body so much that when the symptoms do come, you can tell. And so I was like, just finished chemo, but I'm still feeling the cancer. And she was like, how? I just, we just finished chemo. And I took really heavy chemo. Took me the first set of chemo, 6 months, took about 9 hours a day. And I was getting probably 8 or 9 bags of chemo at one time. So I was taking it really, really toughly. But after it, I just knew, I was like, I'm still not feeling well and something's wrong. They scanned me, did a couple of things, and she called me and she was like, you have triple negative breast cancer and it's inside and outside of your liver. And we never saw it. And so what we did was some more scanning and saw that it was behind my breastplate wall instead of inside of my breast. So they couldn't find it. So that's the fourth cancer that I have. So all of them are terminal, in stage 4. And even with knowing that, I am still grateful because I'm 44 years old and moved past leukemia and all those other cancers that I had for so long, that I'm highly blessed and thankful for God's blessings on top of me being as strong as I am. So I am with 4 terminal cancers. And so recently what happened was, what brought me to the interview today is that I am on palliative care because it spread it to both sides of my brain. I just had a major craniotomy in February, the end of February, from having a seizure. And I ended up just pretty much having surgery on here. And then afterwards, I had to go through brain radiation, which I hated so much. And still trying to make my way back. But what I will say is the accomplishments that I have made right now, is just being able to walk again from that brain surgery. It changes the whole spectrum of who you are. And so being able to walk again, talk again, my mind isn't as sharp as it was. Sometimes I do forget some things and can't think of the name of things. But I'm here and I'm grateful because every day that I get, I'm not focusing on the future. I'm trying not to focus on the past, but it's like this day is what he made for us and we're in it. And so that's where I am. I'm the 4th terminal cancer chick and I'm still surviving.
You to walk in the runway after brain surgery chick. That's who you are, walking the catwalk, ma'am.
Can I tell you, walk in the runway? I'm gonna come back with a video and show you her walk when we do this batch.
Oh, I can't wait to see that.
Because she is fierce.
I'm gonna kill you.
She is fierce, 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 fierce.
Yeah, now we have to show everybody. We do.
Mhm.
Yeah.
Yes.
But, like, look at this story, right? So let's have it, and we'll come back and you can talk about some of the palliative care stuff that you're doing, Julia. Okay, after Steph talks a little, gives her story.
Hello, everyone. Thanks for having me here again. I really appreciate the opportunity. I have been living with metastatic breast cancer now for July the 9th was 6 years. 5 of those years, or 5.5, close to 5.5 years, have been stable, no evidence of active disease. Scan anxiety is about to set in since I get scans next month, and this is my first set of 6-month scans. So I was one of those women, an older woman. I was diagnosed at the age of 56, had done everything right, I thought, and ended up with, metastatic breast cancer de novo. I currently live in Eastern North Carolina, which is considered a rural, predominantly African-American community. And we're lacking tremendously here for resources just about breast cancer, breast health, health literacy. So I am trying to climb this mountain with the support of many online peeps that are going to help me better educate, better prepare the women in this community to ask the right questions, to look for the signs, to be empowered about their knowledge and to be empowered by their own health care. I'm doing great. A mom and a Mimi here, a registered nurse. This is passionate. This topic is passionate for me because I retired as a hospice nurse, and it kind of angers me, but it's also hurtful that people think palliative care and hospice are the same thing. And I'm here to set the record straight tonight. That's what I'm doing.
Great. Love you, Steph. Love you, Steph. So Dr. Kim is a badass palliative care doc that we found. I found you on Twitter, right?
Yes,
Right?
yes.
She's incredible.
So thank you so much for reaching out, for answering my call. But can you just define what it is and what do you do and when do patients come to you and what you do for them? Because I think it's just unclear. I think when people hear
Yeah.
palliative care, they think hospice, they think I'm going to die at the end, whatever. And
Yeah.
you do amazing things. Can you just define it for us? Explain it.
No, that's a really that's a really excellent question. So when patients come to our clinic, what we explain to them is that palliative care, what we are is an extra layer of support. And so for patients who are living with serious illness, no matter where they are within that illness, our team manages the physical, spiritual, and social psychological symptoms that affects you when you're experiencing serious illness. And when you think of palliative care, I sort of think of palliative care as an umbrella and a philosophy and a practice. And we deliver that with a team of people. So if we're delivering spiritual and social and psychological support, then not your doctor can't do all of that. So we have chaplains and social workers and other interdisciplinary or interprofessional team members that add to your team to support you during your care. And that's part of what we do. The other part of what we do, which I think is helpful and I find really meaningful, is that we help people figure out what's most important to them, what their goals are, what their plans are, and then we try to help support those plans. So, and oftentimes where that confusion between palliative care and hospice and having it so married together, I say that all hospice is a palliative care, but not all palliative care is hospice. So if you are just starting your cancer journey and you're going to clinic and you're having lots of pain, or this is very overwhelming, you're really having a hard time navigating the system, then your doctor may say, okay, well, why don't you go to palliative care, and you might get your palliative care delivered to you in a clinic setting. And the goal is curative therapy. We're, like we say, we're in it to win it. And your palliative care team is going to have those goals in mind. If you have an illness that you're going to live with, and now we're going to be in this for a while in the thick of it, then the palliative care team is there to be in the thick of it with you. And what we're doing is supporting you. We're not replacing any of your providers. I say we're kind of like medical caulk. So patients come in and say, well, I don't know why they sent my doctor here. I'm like, well, what's bothering you? I'm like, well, that's why they sent you here. And we do that because that's what you need at the time. When people are approaching the end of life, that's when your palliative care can be delivered through a vehicle like hospice care. Because if you think of everything kind of like a safety net and think of your treatment like a tightrope, right? So the beautiful thing about America is that you can do whatever treatment you want. You can, follow up however you want. But if something happens, we're not just going to let you fall. So services like hospice are there in case if things don't go as we hoped. You still need medical care. You still need help, and you need a safety net that's super, super tight. And so then all that palliative care, all that support is now delivered through the insurance benefit of hospice, because they have all the things that you need to help you feel as good as you can feel for as long as you can feel. So I just tell people it's like a bridge. And then if people don't want to listen to all my fancy words, I just say, I'm the lady that's going to get your situation situated. It is
Oh,
not situated. We are going to stop medical foolishness and get things together for you. And or palliative care like your pals. So sort of think about it like that. We don't replace anybody, and you have tight oncology teams, which are awesome, but people can't be everything that you need. And when things fall through the cracks, somebody has to catch that. And that's what we do, because you can't afford to wait. Your quality of life, if your quality of life is not good and you don't feel good, you can't do this treatment.
wow.
If you feel good and things are together, then that gives you your best opportunity to take advantages of everything our healthcare system has to offer.
You
Wow.
kind of sound like a fairy godmother.
It sounds like the Olivia Pope of cancer to me. It's handled. That's what I heard. I heard Mike drop Olivia Pope, but
Yeah.
you know, I have referred patients with stage 1 breast cancer for palliative care, and
Yeah.
people are always so surprised. Like, what do you mean? It means that there's a lot of moving parts and a lot of help that's needed to get you to a better quality of life, whatever your stage is.
Mm-hmm.
And I think that I love your definitions. They're so easy to understand, and to use those resources, because there are resources available that the surgeon's office may not know how to mobilize and activate, that the social worker alone can't do. And by pulling in all the important people, you know, it really does help the overall patient. So that is tremendous.
It's really amazing and wonderful when everybody else tells you no, and then we're like, sure. And so, the ability to, to be there with people, and be there with them in medical uncertainty, because that's one of the hardest things, because this is what we tell you: you have this thing, and then we give you, and next thing you know, you have 45,000 tests and all these people and all these appointments, and it's just chaotic, and it's hard for you to even catch your breath or to know. And if you don't come from the medical background, you don't come from our world, it's so difficult to navigate. So people talk a lot about health literacy, and it has not always what to do with your socioeconomic background or your educational level. um, this is, everybody is struggling. My patients who have very little and my patients who have a lot, and they're struggling with the same thing, trying to understand this system, trying to navigate this system, trying to advocate for themselves, wanting to be the best, the most perfect version of themselves so they can present well to get treatment, having to deal with disappointment, and all the other things that happen, and to have a team that you can be yourself with and that you don't have to perform for, um, can be beneficial. A place that you can just relax and figure it out.
I have
Just
a
the voice
question.
alone is like so soothing and
Mhm.
peaceful, right? Like you give
It
me,
really is.
right. So Juliet, you told me that you were getting palliative chemo. What's that about?
So palliative chemo, from what I understand, is chemo that sort of does the same thing as palliative care. It's a chemo that try to stabilizes everything when you're heading into a more dangerous direction, I guess. So with palliative chemo, it is chemo that just tries to maintain what has happened already that could be detrimental, and so it just kind of has a, I don't really know what the length of time is. From what I understand, is 3 months to 12 months. How long this could actually last. But then I see all things that say, palliative care people can push through and come out on the other side healthy and things like that. So it is a bit difficult, in this circumstance, because everybody wants the best. Everybody wants the longevity and things like that. So um, it kind of shook me when I had to get involved with it, because of course, you go with the first instinct of what you're thinking next. And I still haven't shooken it all the way. I can't say that I have. I'm glad that we're having a conversation about it, because what I tend to always be is authentic and very genuine about this. And for me, I'm still in between the fence of feeling a certain kind of way about it. And that's just me, because it's, I'm like, wait a minute, but that's what the real is. And so that's what palliative chemo is and what it does. And I'm going to be past that.
Is it helping you? Do you feel better? Do you feel different than you did before you had it?
I feel a little better. Yeah, because one thing I was saying before was I can feel all of my cancer. Sometimes my body will start to burn really, really bad from inside out. You can actually feel it. It's like, why are you so hot? so I can feel that. Or if I strenuously try to exercise or do some things that actively make me move too much, it's a bad feeling for me. So when it does happen, I know it's there. So since taking the chemo, I do feel better. Doesn't feel strong enough, but it does help me make me feel much better than what without it. I've been without it since the brain cancer surgery, so I needed to get back on treatment.
Dr. Kim, can you translate that a little bit medically in terms of if there are clinicians who are watching or people who
Sure.
want to talk to their doctors about what palliative chemo would be? Can you help explain that a little bit?
Sure. And Juliet did such a good job, and you are absolutely amazing. So oftentimes when patients come and they've said they've been offered palliative chemo, they're being offered chemotherapy that we know that it's not able to cure the cancer, but the goal is either to stabilize it. And if it improves, we understand that it won't be able to cure you, but it could hold things off and hold things at bay for as long as it can. So your understanding of it is really great. And I love that you brought up the fact that, you know, back in the day, we associate chemotherapy with feeling terrible. And when I was first trained as a palliative care doctor, the goal was to stop people from having unnecessary chemotherapy. But the world has changed and the treatments have changed. And now sometimes I'm like, can I find some chemo? Chemo, this will not get better until you get some chemo. So palliative chemo has two parts. One is about the disease and the stabilization, but the other thing the patient should also be asking is, how will this chemo make me feel? So when you're faced with your doctor saying, hey, we would like to give you palliative chemo, you think in your mind the questions that you have to ask us white coats are, doc, is how much time is this going to give me, and how much is it going to help me feel better, and what's it going to take away? And if they can offer you a palliative chemo that says, hey, this is going to give you time and this is going to make you feel better, that's the holy grail. That's a no-brainer. If they offer you a palliative chemo that says, it's not going to make you feel great, but it's going to give you time, if time is what's important, then you understand what you're going into and you're willing to pay the cost. If you give a palliative chemo and it says, you know what, look, this may not extend the time, but you know, for a while you're going to feel better. If quality and feeling better is of most important and time is not as relevant, then that's worth doing. The time when the doctor may have a palliative chemo, but may say, or maybe more negative about it and may say, maybe let's not do that, is if it cannot make you feel better or give you more time, then they know, or goodness sake, take time, because the cost of it on your body is too high. Your body's not able to pay that cost. Then that would be a palliative chemotherapy. That would not be a good idea. And that's when your doctor might say, you know what, hey, we have something, but the cost is too high. And if time and feeling good is what's important, it can't give you either one of those things. So let's not do that and look somewhere else.
So one of the things that I had, you know, we had a friend with triple negative recently passed, and she had really horrible pain, and she for 2 years, just like debilitating pain. It was in her lymph nodes. And so, do you manage pain, or is that a different doctor? Is that part of what comes under palliative care as well?
Yes, palliative care definitely manages pain. Oftentimes they say I'm the pain doctor, and being in Atlanta, Georgia, I'm also the marijuana doctor, but that's a whole other thing. Like, you want to get to palliative care, just say marijuana, and all of a sudden we appear out of the woodwork. But yes, we manage pain. So when you think, you might hear this term called supportive oncology. And I like that term a little bit better, because just like everything evolves, like cancer has evolved, this profession has evolved. So when you think, if they refer you to supportive oncology, you could see a palliative care doctor like me who sort of manages everything. Think of more like a fancy primary care doctor that's not afraid of opioids and benzodiazepines. But they also have cancer pain specialists who really work with just dealing with the cancer pain box. And they often come with other procedures. So they'll have medication expertise, but these cancer pain doctors will also have expertise in interventions like nerve blocks and all these other things, because people get really sick and tired of taking pills. Uh, and no matter, even if the pill is really helping them. And also, even under that supportive oncology, some places have cancer rehabilitation specialists where they're physical medicine and rehab doctors and physical therapists that are managing cancer pain. So yes, so in cancer, you have several options depending on where you are to access pain management. But in smaller places, you might find that that pain management really sits in the realm of the palliative care doctor. And then as you go to different areas that are a little larger, that there are other specialties, but we all work together operating from the same principle.
So, Steph, you have no evidence of disease. Do you have pain? Do you have any pain you're dealing
Every
with?
day. I have pain every single day. Um, and it is, everybody thinks that, being a nurse, that I should be on top of everything. I should be aware of everything, but I'm not. I actually, as a nurse, fell through the cracks with pain. I had, during COVID, I decided to get treatment closer to home and didn't switch, I obtained another oncologist at a community-based facility closer to home. And things were rocking along really well. And I had a pain flare up, and he kept telling me that I shouldn't have pain. My scans were fine. My blood work was fine. And this went on for a few weeks. And I finally said, no, can I see a palliative care specialist? And I never got a response. And one day when I called, I missed his call back to me. And the recording that I listened to was, Stephanie, I don't understand why you're having pain. Your scans are fine. You're fine. Your blood work is fine. I think the pain is in your head. So with that being said, I didn't know where to go with it. They were affiliated with a university-based facility that has palliative care. It may not be on their campus, but they have it at the main hospital, which I would have driven the 2 hours to go, but I was never given the opportunity to. They told the person that I was not in a situation that I could drive myself there. I'm very able and capable of taking drive myself, bathe myself, obviously feed myself, but I wasn't given that opportunity. So I reached out to some advocates online on Facebook actually here and said, this is what I need. Can somebody help me? So I had a friend that was in Lake Tahoe, California, reach out to 2 physicians here in North Carolina. And when he read his email, he called me immediately that morning at the facility that I was going to initially at Duke, and connected me with a physician. And I was sitting in his office a couple of days later and said that it was wrong for me to be told that. I do have pain, and even as an old ER nurse, I know pain is what it is to the person, what their perception of pain is, it's true to them. It may not be true to me, but that's what they say it is. So, and being a hospice nurse, I deal with, helping manage people's pain all the time. So when my doc looked at me and said, you know what, I'm going to give you 3 days around the clock of morphine. You talking about someone's rear end puckering. I'm thinking, no, stop. I don't take meds. I don't want it. And morphine of all things, you know what I mean? It's like, I did it for 3 days. And my goal wasn't to be pain-free. My goal was to be back to where I can walk my dog, walk my 3 miles in the morning, have some quality of life without crying or being in a ball in bed. That's where I wanted to be. I wanted to be back to those things. So I say my pain level, if I can get it back to a 3 or 4, I was happy. So I did what he said, and I'm going to tell you guys, I missed 3 days of my life. I did. I slept like a big old girl, but I was pain free. I did what he said and managed it. And then after I did that, he sent me to someone. I forget what they call them. They have a name where they do the spinal injections and stuff for pain. I mean, no pain for almost a couple of weeks. None, zip, none, nada. So, I fell through the cracks. If somebody like me that has a little bit of knowledge about healthcare can fall through the cracks, I can't imagine what other people would go through. And it's not right. You may not have it at your little tiny, community hospital or cancer center, but you can always ask, have somebody to help even if it's a pain specialist person, it's better than nothing. So I'm a big component now that, that morphine's still sitting in the back of my medicine cabinet and it'll stay there for a long time. But at least I know that I have somebody that listened to me.
Yeah.
And that's all
And
I want.
I love that you shared this story, Stephanie. And the reality is, like, how many people could just benefit from giving their body a break, right? From giving those pain receptors a chance to just recover and just allow your body to sleep. I mean, how amazing and how restorative is it? Because the reality is a lot of people don't sleep well. They either have trouble getting to sleep, or they have trouble staying asleep, or they got to get up and pee a bunch of times, or they're stressing out and they're perseverating on things. And these are people who don't necessarily have a diagnosis of cancer. And so how much more important is it for your body to just take that break, right? And for us to give ourselves permission to do that. And so that was a big girl move. You're right. That giving yourself permission to do that was huge.
Like giving your body a vacation, right?
Exactly.
And Stephanie,
it was great. It reset a lot. It resets you mentally as well. Pain causes fatigue, man. When you're in pain a lot, you're tired. You snap at people. My husband was ready for a divorce. I'd already moved to the other bedroom, and it wears on you mentally hard. And that was during COVID time, and I had to seek out mental health because I was ready to jump off the mountain. So, and I'm not embarrassed to say.
And Stephanie, I wanted to say I am so sorry. I can feel it through the Zoom, what that was like. And that was wrong. And we do that all the time. If we don't know what's wrong, we make the patient feel like they're wrong. And our fear, when we hear somebody has pain, our fear of the opioid crisis and all the things that have nothing to do with you, that has everything to do with us. So we have countless numbers of people out there suffering that aren't asking us for what's wrong, but we can't see past our own fear. Your emotional state can definitely affect the way you perceive pain, but people are not crazy. They're not crazy. And, it's our due diligence to look and then to offer options and to take the time. And that's never okay. And that happens more often. And even your ability to advocate in the area of pain is difficult because all of those things you felt was happening. It's almost like they gaslight you into thinking if we just tell her, it's not real, she'll believe it's not real. But it is real. It is real. And no, negative scans doesn't mean you have pain. We put your body through the ringer. This treatment costs you things. It takes things. It costs, and you're lucky to be alive, but you don't get out of it scot-free. So it's the illusion that, you ring your bell and then you go off and back to life as normal. And it doesn't work that way. It's not the same.
Doc, I would dare say that not enough of us are taught pain management in medical education even, right? So, and what I mean by that is we certainly learn about pain receptors, but like multimodal pain relief, like how treatment algorithms and ways to manage and to escalate and de-escalate and all these things, I think are areas that in medical education we really need to do a better job of, because you're right in that when we reach that place where we feel uncertain and we're not able to manage, or we're at the end of our personal knowledge, there is that tendency to blame the patient or to say, you know what, we've done our part, it's, this must be you. And it really, it's ignorance on the part of doctors. Absolutely.
I have a question to you, and maybe this is for you, Juliet. When did you seek out palliative care? Like, did your doctor offer it? Did you ask for it? Like, how did you know about it? How did you find out about it?
Me first.
Yeah.
I didn't ask for. Given to me after, like I said, I had a seizure and ended up going to the hospital, and they found 2 tumors on both sides of my brain, one in the frontal lobe on the right side, and then in the temple on the left. So it was a bigger one on the left that they needed to do surgery. And so when they did all of that stuff, and afterwards, they still were not really feeling this area being clean and clear, and then they had this area to deal with, but it wasn't as big, so they didn't need to do surgery. So went through the radiation, and after the radiation, I have a team of doctors and oncologists that get together in a board to try to weigh specifications as to what to do with me, because of there's so many cancers, and they don't have just one, you know, chemo prescription to take care of all of them. And so that's what basically is, their thing, to sit down, what will we treat? What's the worst? What's going on? And as a group, they come together and come through my oncologist to to decide what they're going to do with me. So that's when she made the decision from the board that she goes to for me, to put me on that. I'm actually on a colon cancer chemo. So as we know, colon cancer is one of the high ones, the very number one rated ones. And I have had about 4 or 5 different types of sessions of chemo. I've done, whatever's out there almost. And so I think that was her decision to put me onto that. But there's a but, because I'll always continue. Yeah. So
Yeah, but you're
hopefully
living.
that was funny to everybody.
Gosh, so how can we help people know about this, and breasties who may be struggling and not know where to turn or how to ask for this? Like, and Mo, you even said, you offered to somebody in stage 1. Chemo sucks, okay? And so, I mean, if there's stuff you can do while you're just on chemo that can make you feel better, you should do it, right? I mean, doesn't matter what stage you are.
I wonder if it is, an underutilized resource, or if you're starting to see more consults than ever, and it's becoming, the floodgates are open because people realize that they need so much more help and so much more support. So I'm curious to know the state of it, but also maybe how to prioritize those patients, and how do you, if everyone seeks out palliative care, is there something for everyone, or are there other services that we can refer patients to learn to utilize resources, financial navigation, other things like that? Like, who's maybe not appropriate for palliative care consult, once you tell us how people can access it, because I think more people are appropriate than they realize.
Yeah.
So 2 questions.
No, that's a really good question. So ASCO, like the big Grand Poobah organization from oncology, actually says anybody with an advanced cancer should have access to an interprofessional palliative care team, so specialty palliative care. So that should be a standard of care in the magical world we live in, where all resources are equal. So it depends on where you are in the part of the country and how much access. So people like me that end up being trained and are often concentrated in larger cities. You may have some of us here and there, but the workforce just isn't large enough. And palliative care providers, advanced practice providers, social work, everybody, all these people who are trained, there's just a limit to that. So the beautiful thing that hospices did is they thought, okay, we're already delivering hospice care, so why don't we spread community-based palliative care, where they actually send nurse practitioners and borrow from their hospice team to go into homes of patients. Because sometimes if you're really sick, you can just get to chemo and you can get home, but you can't stop and see Kimberly. You just can't do it. You're tired. So the hospice agencies have been really thoughtful. They had the work staff and the expertise to branch into this palliative care. So sometimes in places, at least like in rural Georgia, they really make palliative care possible in places for adults and children. And that's how we're sort of cobbling that together. However, if I tell you that everybody should have it and there's not enough resources, then what do people usually do? Well, now, you better learn how to figure out how to do it yourself. So training oncologists in basic palliative care, we call it primary palliative care. And so if you go to a cancer center and you love your oncologist and you call them up and you're like, you have pain and you're nauseated and they are like on it, they are palliating you. They are doing primary palliative care and they've got it and your team has it. That social worker, that financial counselor that's available, all of those other support staffs that don't have MD or APN or PA behind their names, they're all part of your cancer-based team. When your symptoms are pushing past their expertise, like like they have you on medicines and you're saying something, they're looking at you like, we've used everything I know how to do, then they might seek out somebody like me, that a specialty palliative care provider. So when your needs are pushing out beyond, and the truth is, when you think of entering a palliative care relationship, sometimes people need me every day. Like they're on my cell phone. I'm like texting them before they go to bed at night. We're FaceTiming each other. And then there are other people who are doing great and just need you when you need you. So the ability to float back between specialty palliative care and primary palliative care, if the services are integrated and we all know what each one's doing, can work really, really well. So I think that's probably the way to sort of access it. So I don't want women to feel like, oh my gosh, I've been getting all this substandard care and nobody's cared for me. Well, no, your doctor's been doing a really, really good job for a long time. It's just that, like everything, it's more complicated. It's more complicated. So when it's super complicated, that's when you're probably going to see me. If it's simple, they're not going to make you pay another copay because who has time for that? But when it's complicated, then let me see you. And when it's not complicated anymore, then your wonderful oncology team can get right back in there and pick that up. So that's sort of how I kind of think I think about it, and I think about the future good basic primary training that all doctors should have, and advanced care, like we all should have in healthcare, and then that way we can make the specialist stretch.
I think we need to get Juliet and Stephanie Dr. Kim's cell phone number. Right? Are you getting that great kind of care?
Wow. I think your voice alone is better than the Calm app. I mean, honestly,
I'm telling you, right?
yeah, you could really do some meditation and some affirmations and some other things. And I know you have a podcast, right? And you do have a podcast, right, Dr. Kim?
No, I appear in other people's podcasts and answer questions, but yeah, no, I don't have a good grief. I don't have a podcast.
I predict before the end of the year, you probably will.
You can come on here anytime and talk to us. We love your voice. It's so beautiful.
And another thing is, it's just not for cancer patients. It's for those excuse me, those patients sometimes that have chronic illnesses that have symptoms and the side effects from their disease anyway. And one of the most common ones that I think of are CHF and COPD, that have symptoms that aren't managed, or that are chronic diseases that are going to have these problems, and they're going to die with those eventually too. But heart failure, or stop breathing with COPD. But those people can benefit too. I remember having a hospice patient that was COPD, and he was given just regular breathing exercises when he started to feel anxious. And he was on palliative care. So it's just I don't want to say it's just for everybody, but it extends outside of cancer. And I'm a firm believer too, as Dr. Mo made the comment that she had a patient that has stage 0. I think every patient that is diagnosed should have the option, or have that as part of a team, be part of their team as well.
Yeah, I was thinking the same thing. My mom has COPD, and she has these anxiety attacks when her oxygen is not right, or something happens, or
Exactly.
you can't breathe. And
when you can't breathe, guess what? You get anxious. Oh, what? And then you're anxious.
right, and then you're anxious, and then
You can't breathe.
Circle.
It's like a vicious cycle. Yeah. So I really believe this would be a really good. I'm going to recommend this for her, because it's a really good way just to. I feel like you're giving peace. You're giving solutions that give peace. And I always say your peace is non-negotiable. So if there's a way to give you peace, you should take it. I mean,
and peace for your family too. Like, I have some patients who don't need me at all, but their spouses do. And so when you think about a palliative care service that's integrated, it takes, you whatever you are going through physically, if you're married, you have kids, if you're a mother, daughter, if you are connected to another person, they are doing this with you. And every choice you make, every up and down, they're not experiencing it physically, but they're experiencing it in this way. So when you're sick, the whole family unit is sick. And when mommy's sick, everybody's sick.
yes.
Like, it just doesn't work right. So oftentimes, if we're not working directly with the patient, sometimes, people will get a referral for the family, because there isn't a good place to go. Mental health resources in this country are terrible. And so oftentimes people will access palliative care just for the mental health resources, because we can't get it together in this country to have good mental health resources. But, if we know this is the standard of care, like if something was the standard of care in hypertension or in surgery, it just happens. This is one place where we all know it's the standard of care, and we don't fund it. We constrict, how many people are doing it. We're all confused about when to refer. You don't need another study to tell you water's wet. But it will change, I think, when the patients advocate for it, when it becomes a demand where you say that I will not do this without the proper support.
Wow. And so, Doc, I think, one of the first places that patients can start. So if you're watching your patient, or if you're a caregiver, you can start by asking your doctor the questions like, what does palliation look like? Can my loved one benefit from palliative care? Can I benefit? Have we been doing it all along and I didn't know it, right? Or how can we incorporate palliative care into our treatment plan? Like, that's a really simple question, because sometimes you don't know the question to ask. And so the first step could be just asking your doctor, have we thought about, and how can we incorporate palliative care early, not at end of life, but early, so that we can have a better quality of life overall through this treatment, through this journey, through this disease into wellness, And so I think that that's a really powerful place to start, just by asking that question.
Yeah. And one thing that patients will sometimes get pushback is because just like the community thinks palliative care is saying that I'm no longer going to participate in therapy, a lot of the oncologists worry about that, and that's probably how we were birthed. So as a patient, they say, "Doc, I want palliative care, but my doctor won't refer." I say, go and ask them, say, "I want palliative care, but don't worry, I'm coming to chemo. See, I've signed up the clinical trial. Its ink is dry." My port is in. But if you say, "I just need, come from
Mhm.
a place like," and say, "I need help." And then you also have to let them know when somebody's been caring for you, doctors aren't magical, like fairy people, the white coat. We are emotional creatures. And if we've been caring for you and leaving it all on the table for you, and then you come and say, "Hey, I want this other girl to come and talk to me or manage my stuff," we get caught up in our feelings about that. So sometimes you almost might have to say to us and say, "You're giving me, and I'm so grateful for this care, but I need a little extra help. My family needs a little extra support. Would it be okay?" And that sort of puts them in the frame of mind. You're not telling them that you're failing. You're not telling them you want to leave them. You're not telling them you disagree with the treatment plan. You are asking a different question, because sometimes when you're asking for palliative care, they hear something else. That's a little behind the curtain. I shouldn't be saying this aloud. I might get my doctor card taken away.
No, you will
No,
not
that's
have your white
good.
coat taken from here,
They're
because
like,
you're absolutely right. We are on the side of the patients here and helping the patients to navigate these systems. And it's so important to know that your doctor is a person, that your doctor makes mistakes, that your doctor has doubts, has fears, that your doctor worries about you and takes it home, that your doctor is pushing for you, that your doctor is trying. Like there is so much that goes into the dynamic of cancer care, especially, that's so complicated. And I'll give you the prime example. Ricky always says, "Oh, everybody get a doctor like Dr. Mo." Sometimes I'm just trying to get a person to understand their diagnosis, to understand what hormone receptors are, to understand their treatment plan. We don't even get to the other stuff like sex, like intimacy, like finances, like this, like that, and not in that one encounter even. And so even I feel like I fall short of the standard I set for myself. And
No,
so it really does take a village, and palliative care is a part of that village.
and I hope that when I get to the point to where I'm tired or it's not working for me anymore, now that I am a patient in palliative care, I hope I can slip silently over to hospice care without a battle. And I've seen from both ends the battle where the palliative care is ready. They are requiring more supportive management, more supportive treatment, and to get that original base of relief for the patient. And the patient said, it's enough. For me, it's always going to be quality of care, for a quality of life for me. I want that quality of life. Quantity, I do want to live forever, not forever, but for a while. But I want to have it to be a quality life. And when I get to the point to where I can't have that quality of life from Dr. Mo giving me my chemo, and Dr. Kim trying to manage my vomiting and my side effects, then I'm going to say it's enough. But I want to go into the next phase of the palliative care realm while I still have a quality of life to determine and dictate the end of my life. So, that's how I want it to occur. And all those around me know that that's how I want it to occur. I don't want it to be one of these doctors that has an ego the size of Jupiter that wants to hang on to me and try everything, whether it gives me a quality of life or not. And then I end up in hospice care at the very end, miserable, and they are unable to get me comfortable, and I die miserable. I don't want that. I want a good quality of life all the way through the very end, and I want a quality death, if that makes any sense. Um, and that's why I want to stick with palliative care. If I don't need my doctor, and like right now we're just seeing each other every 2 months now. And pretty soon I'm not going to really need him to keep checking in on me to see how I'm doing. I'm sure he knows that I will reach out to him if I need him. And that's the way I think it should be. You know, you have enough doctor appointments. You don't need to have a doctor appointment with him every month. You have to say, hey, how's it going? How's the kid? Yeah, how's the dog? You know, I don't need that. You can call me and tell me that. But I think that you just need to have him in your back pocket in case I do need him. And that's okay too. And patients need to understand you don't have to keep going just because you have a doctor doesn't mean you have to go see them all the time. You can just have them there in case you need them.
No, that's an excellent point.
Yeah.
And if women wanted to advocate, I think, and trying to look at a rallying cry is redesigning how we do this whole thing. Like, so everybody needs something a little bit different. And I'm not entirely sure that you have to stop your cancer therapy and not have this support that you need from hospice. The idea being, you know, having both things at the same time. Maybe, you know, we have to start bending our mind a little. And I know Stephanie's probably seen the evolution of hospice, and before, like, IV fluids, oh my gosh. And now we're like, well, sure, blood transfusion. What are you talking about? You're in hospice. And they're like, TPN. You know, like we are slowly, at least in my profession, starting to realize that some of the things that we think that have barred people from entering or seeing us are these hard and fast rules about what you can do and what you can't do. So we have to think about, if this is providing you comfort or helping you reach a goal, let's do it. If it's neutral, hey, let's try it. If it's harmful, let's not do it. And that should be how we think about delivering palliative care services and hospice services at the end of life, to allow people to slide and make that transition without it being so abrupt. And, you know, and then we also need to really talk about, as Black women, we got to talk about this thing. We got to prepare our families. We got to have these conversations. They're hard, they're scary,
They're hard.
but you know,
That is
if
so
we
great.
if we are carrying the brunt of our community, our absence suddenly creates chaos. So if we have prepared for it, just like we prepare everything else in our lives, and that is not claiming it or giving it up. You know, you are not claiming you're going to have a car accident if you buy car insurance. You're not claiming something bad's going to happen if you just tell me who your person is.
Oh, I love that. I love that. You're not speaking it into existence. Come on.
Mm-mm.
Right.
Nope. Nope. And then you can't get it wrong. And then when we ask people what their choices are, then we can't berate them for those either. So that's on our profession in palliative care to want, if somebody tells us this is what the goal is, I can make you feel good. If you want to do the exact opposite of Stephanie, if you want everything and all the bells and whistles and everything, I can still help make that not miserable. So.
Juliet, what would you say to your breasties who are struggling with this, what to do and having pain and having issues, and what would you tell them?
I can't say that I would have any expertise type of things to say towards it, because I'm still struggling as well. I'm just, a human being who wants the best for myself and everybody else, so it's like I'm still in the struggle. So I don't want people to think that I'm just like, and we have this hope and this is great. I can't do that. I'm authentic in this walk, in this journey of mine. And what the authenticity demands is for me to always be truthful and honest. And so I'm still in the struggle with this. I had to write my will out, and that was very difficult for me. And so I'm not ready to go anywhere, So I'm like, my thought process in this manner is to always stay in touch with my soul. And the person that made a soul for me is God. And so that connection is always going to keep me on my strength, even when I'm weak and sad. It's only for a split second, and then I gravitate back to understand how grateful and merciful He has been over my life, and still is and still will be. And so the one thing I can say is just make sure that you are one with your soul and the universe or God or whatever it is that you praise. Keep connection with that. Don't concentrate on this. Don't concentrate on palliative care. Don't concentrate on the cancer. It's here. We already know what we have to go through as a routine. But what we have to understand is that just keeping that mindset focused on I'm living, I will not die. I'm living, and that every day you get to live is a confirmation. So that's the only thing I can tell.
Bless you. Bless you, my
That's
bestie.
beautiful. Absolutely.
Wow, you guys are so awesome. Thank you so much.
Thank
I hope we're
Thank
helping.
you.
Yeah, this is incredible. I think that we should revisit this, hopefully
Yeah.
before the year is out. And if people are watching and you plan to talk to your doctors about this, we want to hear from you and we want to have you on the show. We want to understand how you are able to incorporate some of this and make your cancer journey just a little bit better. So my challenge to people who are watching, I challenge you to have these conversations with your family, with your doctor, and really start thinking about how we can incorporate this into your whole treatment plan and your team. Like these are folks who can be helpful for you. And once you find that it is, we want
Right.
to hear from you and we want to know how it has helped you and we want to help and empower others because that's really what this is all about.
It is. It is. How can people reach out to you if they want to reach out? So that you're like so active on Instagram. So I love your Instagram.
Me?
Yeah.
Oh, okay. I was like, oh, wait. Okay. Well, people can reach out to me. I do have a lot of DMs and things like that from other cancer patients and survivors and thrivers and things like that. And we develop friendships and just that place where you can be honest about how you feel, because the world is always on positive vibes and be nice and be kind and don't bring in any negative energy. But a cancer patient is going to have some energy that might not be positive because they're going through I don't know what. So I'm always open to anybody's that DMs me and wants to talk and share what they're going through or whatever it is or having a bad day. We can cry together, but we're not gonna stay there. So that's the difference. But you are allowed to cry and be pissed off because I've been there. So you can reach me at my main page is at Juliet Unbound on IG, but that's my business more so outside of cancer. But I am the CEO of Cancer Doesn't Have to Be Ugly. So if you say, put at Cancer Doesn't Have to, the number 2, be ugly, you'll find my page. And again, I'm more than open and willing to talk to counsel with anybody, things like that. I think that God gives us gifts that are weird sometimes, and I'm the sick one that always gets called. So yeah, so that's how you can reach me.
Good. I put it in the chat. Steph?
Oh gosh, Facebook, Stephanie Walker. I'm on Twitter. Face of Stage 4 is a good one. I'm learning Instagram, so just Google my name, find me, Stephanie Walker at Stephanie Walker 1303 at gmail.com.
Great. Great. Dr. Kim, they need you. We need you.
I am on Twitter at Cursine. So, but I currently work at Atlanta at Emory Healthcare. And so if you go to the Emory Healthcare Palliative Care page, you can find me there. But yeah, I'm on my Twitter. I do not have an Instagram page. I have a Google Watch. It keeps dinging and I don't know why. So so I cannot manage a good Instagram, but I do understand Twitter. That I understand. And but yeah, if you have questions, please feel free to reach out. Emory Palliative Care and Supportive Care, that has an email there, and then I'm more than happy to ask questions. Palliative care world is small, so just like Stephanie had to reach out to somebody in California to get her all the way to Duke. That's just how we roll. So yeah, so if you're trying to find somebody, and another great resource is getpalliativecare.org. That can find palliative care providers within your area.
Right. Great.
Yeah.
And I did
Oh, I
reach out to you
love
on
that.
Twitter, and you tweeted me back instantly. So thank you for that.
Because I understand it.
Yeah, me too. I love Twitter. Twitter's my favorite.
I'm still
So
figuring out the Twitter. I tell you, I'm good on the Facebook and I'm learning the Instagram, but I can't keep up with the posts and the stories and the videos. Like I want to do more interactive things and just post a picture, and I haven't figured that out yet. And don't even get me started with TikTok. So much work to do.
much work to do. We have 2 surveys that are out in the world, and you probably have seen them on our Twitter and our Instagram and our Facebook, you guys. Stephanie is working on a wonderful survey called Project Become, and we're going to put the links in the chat. And we would love for our breasties to help us help eradicate Black breast cancer. And the only way we're going to do it is to learn more about how people are thinking and talking about clinical trials. So we have 2 surveys out there. Actually, the survey that we're doing, Black Data Matters, breasties, you can get $200 if you fill it out. So fill them out. Tell us how you feel. We really want to use this information, and Steph and I are going to work together in a couple of months to put the data together to really be able to paint a picture on how we can do a better job talking about clinical trial research and getting our breasties engaged in the science conversation. So guess what? We can try to get the drugs that we need to eradicate this horrible disease. So it's all in the chat. And I love you guys. Thank you so much. And sorry for speaking
I
back
appreciate you.
wicked cold.
We couldn't hear it, honestly. But we hope this has been relatable and reliable and real is what we set out to do every single Wednesday night at 6 p.m. And we will see you next Wednesday night. We're going to talk more about all these topics. Dr. Kim, thank you, thank you, thank you.
Thank you.
Juliet, I can't wait to see the catwalk. I cannot wait
Oh,
to
Lord.
see the strut. Let us know
Catwalk.
how we can support you, how we can celebrate with you. We can cry with you. If you need anything, you know how to reach me. Stephanie, I'm going to really blast your project and the survey and make sure that we get those numbers for you. And yeah, the doctor is in.
Doctor is in. Breasty love.
Bye.
Resty love to everyone.
Thank you. Love you. Bye. Bye.
Bye.